For this part of the lecture, we're going to get into the specific types of dyslipidemias. And the main categories are the primary, which are the genetic ones, versus the secondary. This is different than in hypertension. When we talk about secondary hypertension, those are going to be the more rare types of hypertension. Versus here, it's the other way around. So primary are going to be the more rare and genetic types of dyslipidemia. So these are commonly known as the familial hyperlipidemias. And then the secondary ones, which are more from our modifiable risk factors, so like diet, lifestyle, and other comorbid illness. Obviously, the secondary dyslipidemias are probably the ones that are the most common and the ones that are easier to understand, so we'll start with those. Obviously, here in the United States, we've got a lot of this secondary dyslipidemia going on. So 1 in 4 people are going to have it. Again, the major complications come from atherosclerosis. So you've got coronary vascular disease, going to coronary artery disease, peripheral artery disease, stroke, chronic kidney disease. The other complications that we haven't talked about specifically are from the increased triglycerides, which tend to cause cholesterol stones and can cause and lead to pancreatitis. Probably, of course, the most common cause is poor diet and exercise, but we're going to talk about some other causes of secondary dyslipidemia here too. So here's an entire chart of these things. I don't want you to memorize all of these specifically. Just kind of know that these are other causes of dyslipidemias that may not, be specifically, obviously a lot of these things are related to poor diet and exercise, but you want to have these other risk factors in mind too. So for type 2 diabetes patients, because of the insulin resistance that's going on there, you tend to see increased LDLs and increased triglycerides and decreased HDLs. When you have basically backup of bile, bile is the main place where you get rid of cholesterol. And so if you can't get rid of that, you get that lipoprotein accumulation and you get increased LDLs. Nephrotic syndrome, so you have a decrease of the plasma oncotic pressure. Some of the mechanisms suggest it's because there's an increase in the cholesterol ester transfer proteins, but this tends to cause increased LDLs. And then a lot of these things, alcohol abuse, chronic kidney disease, and hypothyroid disease tend to cause a decrease of the LPL activity. And remember, we talked about this from the previous section. If you have decrease in LPLs, well, then your LDLs and triglycerides tend to build up in your blood. So lots of different issues come from alcohol abuse, chronic kidney disease, and hypothyroid disease. And then we've got some medications that can cause problems with dyslipidemia too. So specifically thiazide diuretics, hormone replacement therapy, specifically with estrogen, and beta blockers. And you can see this is a problem, right? Thiazide diuretics, beta blockers, medications that we already treat coronary or cardiac disease with, and specifically hypertension. So these things tend to go hand in hand. So obviously patients that are on these tend to be on statins also. Clinical presentation here is pretty simple. For secondary dyslipidemia, it's generally asymptomatic, right? Early atherosclerosis is asymptomatic. People don't complain about their dyslipidemia. They're generally screened for it and they're taking medications. Things are different though with primary dyslipidemias, and you'll see this when we talk about these later on in the talk. These tend to present as xanthomas or collections of lipids in the skin. There's a lot higher levels of the cholesterol with primary dyslipidemias and the problem with not processing them at all because of deficiency of specific enzymes. So you tend to get these really just severe deposits which show up as different clinical manifestations. What we're going to talk about now is the basics of diagnosis and management of dyslipidemias. Obviously, this is going to be a big part of anyone that's practicing family medicine. So really, if you have someone with high cholesterol, right, high LDLs, high triglycerides, and low HDLs, you're going to treat them with an appropriate cholesterol-lowering medication. That's generally going to be a statin. What complicates this action, right? The thing is, when do you do a screen? When do you treat or when do you screen patients? How do you know which ones you screen for? Do you screen 5-year-olds? The next thing is when you do see a dyslipidemia, when do you treat it, right? How bad does the dyslipidemia have to be before you treat? You don't treat every single dyslipidemia that's out there. And then the question is, which therapy do you use? And so we're going to talk about all those. Before we get into that, specifically though, when we talk about statins, I want to go over this again, even though I talked about it before, is that statins are HMG-CoA reductase inhibitors. So they inhibit the processing of HMG-CoA into cholesterol. Okay, so this decreases the production of cholesterol in the liver. Because of the decreased cholesterol levels, the LDL receptors are increased, and so you get more endocytosis of LDLs, right? This more of this transcytosis and not just kind of like the LDLs bleeding into the vasculature. This also decreases endothelial dysfunction because of decreased prenulation. Okay, basically you just have decreased damage is what I'm saying here. So who do we screen? How do we diagnose patients? Okay, we do this through a lipid profile, right? You take blood and you do a cholesterol panel. We talked about this before. It generally shows you the total cholesterol, HDL levels, LDL levels, and possibly triglycerides. We'd already talked about too. It's calculated. The HDLs and triglycerides and the total cholesterol is directly measured, but the LDLs are calculated. Okay, so you take the total cholesterol, you subtract the HDLs, and then you subtract the triglycerides divided by 5 if you're in milligrams per deciliter. So that's what the tools that we use to screen. Who do we screen? These are the recommendations that I want you guys to know, are the ACC/AHA recommendations. So first, you get fasting levels of the total cholesterol, HDL, and LDL levels every 4 to 6 years for normal risk patients. Okay, if they have one of these risk factors, then you can do it more often. And a lot of people do them yearly at this point if they have any of these risks. So obesity, smoking, hypertension, diabetes, personal history of cardiovascular disease, right? If they might have hypertension, you should be screening for their dyslipidemias too. If they have a family history of cardiovascular disease, then you should be screening these patients too. Again, because of where we live in the United States, any of these risk factors generally means that patients are going to be screened for their lipids every single year. And that's what happens. So these are the guidelines. Know these. There are more kind of like granular guidelines for screening, right? Screen men, and these are the USPSTF guidelines. I don't want you to know these, but there is a reason to, these are all based on evidence-based medicine. And you can see they get really specific. Screen men older than 35 years old. Screen men 20 to 35 if they have an increased risk. Screen women 45, right? There's all these different things. Younger than 20, only if there's increased risk factors or just to get a baseline. The reason this is because statins are not great medications. Everybody's on them, but you've got to be really careful who you start statins on. So the main reason I wanted to talk about those other guidelines is that we still are very selective on who gets statins. Basically, there's 4 categories of patients that get statins. Any patient with any form of atherosclerotic cardiovascular disease, they get statins, right? If they have a history of an acute coronary syndrome, or if they just have stable angina, coronary or other sort of arterial revascularization, right, a percutaneous intervention, any type of stroke, or even just a TIA, or active or a history of peripheral artery disease, any of those patients, they should be on a statin. Patients with LDL cholesterols that are greater than 190 milligrams per deciliter, they should be on a statin. If patients are diabetic and between the ages of 40 and 75, then basically any LDL levels, they should be getting a statin, right? You see between 70 and 189. Of course, if they're diabetic and they have 190 plus LDL cholesterol levels, well then they get statins too. But you can see we've lowered the bar for patients that are diabetic because diabetes in and of itself is a risk factor for atherosclerotic disease, right? It doesn't have to be included with their LDL levels. And then patients without diabetes, if they have an estimated 10-year risk of ASCVD risk of greater than 7.5, then they should be on a statin. I don't know if you guys remember, this is something that we covered in Intro to PA, this ASCVD risk calculator. It's just a lot of questions that you go through. You can pull it up on your phone on an app, and you go through it with patients, and you calculate what their 10-year ASCVD risk is. If it's greater than or equal to 7.5%, then they'll be on a statin. So why are we so selective with this medication, right? If it's so common, what's the point of being so selective? Can't we put everybody on it? Well, remember, there's a lot of risk that goes with it. You've got to check liver enzymes pretty regularly at the beginning, and patients can have pretty good myopathies with it. The other thing that we've talked about in our research class is that it has a very high number needed to treat. Okay, so if their risk is very low, it's not. It really takes a lot of people to be on it to get a benefit of lowering their adverse events of things like MI. So you basically need to find patients that are at higher risk for these events, like those with history of ACS, like those with diabetes, and those are the ones that you focus on treating, not just everybody. This is the ACC-AHA algorithm of what we just talked about. This is going to help you identify patients that fit into one of those 4 categories. So you see, as we focus in here, the first thing you start with is patients that are older than 21 or older, and they're a candidate for a statin therapy. Okay, if they have clinical ASCVD, then yes, you start either a high intensity statin if they're less than 75 years old, or if they're greater than 75 years old, you can start them on a moderate intensity statin. Okay, and we'll look at the groupings of high intensity versus moderate intensity statins. It says here, if the patient is not a candidate for high intensity statin, and that tends to be on the side effects. So if you start them on high intensity statins and they have liver enzymes increase and they stay increased, or they have myopathies, then you can try a moderate level to see if they can deal with those better. If the patient doesn't have any clinical ASCVD, then you look at their LDL levels, right? This is the second category. If they're greater than 190, high intensity statins again. If not, then you go to those diabetics. And if they're diabetic, they basically get a high intensity statin. You're not going to see that many people that have diabetes that have lower than 70 LDL, okay? So for patients with diabetes, either you put them on a moderate intensity statin, or if you've calculated their 10-year ASCVD risk to be greater than 7.5, then they're probably candidates for high intensity statins. This is definitely one too where you generally see most people using the high intensity statins first instead of going to using moderate intensity. A lot of people just go directly to high intensity statins. The other useful piece of information on this chart is to see what the high intensity and moderate intensity statins really help with. You can see that over here on the left, the high intensity statins are predicted to decrease your LDLs by 50% or more, whereas the moderate dose intensity statins tend to decrease by about a third to half. So, some of you may have looked at that and thought, well, what about statins in people under the age of 20? Remember, there's a really high number needed to treat, and we're very selective for these. So these are some questions that kind of go into why we don't necessarily treat patients under the age of 20, right? Why do we put teens or young adults on a statin early when long-term use in age groups has not been tested? Why label a teenager with a disease that can cause unnecessary anxiety? Why give a young athlete a statin drug that might affect muscle strength? Why trouble a 17-year-old with facts about statins and pregnancies and the potential? The reason I put this on here, these are definitely things you should consider for patients that are very young. On this part of the algorithm, now we're getting into patients that are either not diabetic or they don't have really high LDLs, and we want to calculate their ASCVD risk. If you look here at the green box, the smaller one, if you have a greater than 10-year ASCVD risk, then you're a candidate for moderate or high intensity statins, whether or not you have diabetes or not. Patients that tend to be in the lower risk category but still have some risk is this 5 to 7.5% ASCVD risk, and they're candidates for the moderate intensity statins. All the other groups you can see here, people that have a really low 10-year risk at less than 5, or they're younger, they're lower than 40 or greater than 75, and they have a lower than 190 LDL. These patients are just, you should have a discussion with them. Okay. Same with patients that are diabetic, but they're really young or really old, or again, that really rare diabetic patient that has an extremely low LDL cholesterol of less than 70. These are patients that you have discussion with about lifestyle, and then you really talk to them about if they want to take statins. You talk about the side effects and risk factors and that they can take them, but their benefit may not be as much as these other people that are higher risk. I won't ask you the specific dosages of what the high intensity versus moderate intensity statins are, but I just wanted to share the chart so you know. Here's the chart again about the regular cholesterol lowering drugs that we use, right? We use statins, definitely number one by a long shot, but there are still some uses for fibrates, niacin, bile resins, and obviously ezetimibe for any severe cases. One of the newer managements that are out there are PCSK9 inhibitors. So these are really good LDL lowering agents. They're monoclonal antibodies that block the activity of a protein called PCSK9, which is something that degrades LDL receptors. It's just for normal recycling of them. So if you inhibit these PCSK9 proteins, well, then you tend to have an increase in LDL receptors. If you have an increase in LDL receptors, well, then you get more of that receptor-mediated endocytosis of the LDL molecules, which is, right, again, we talked about this already, it's just more advantageous to go through the endocytosis versus the LDLs just spilling into the vasculature. The specific PCSK9 inhibitors are evolocumab and alirocumab. So that's Repatha and Praluent. And, you know, they're really good medications, but they tend to be injectables, or they are only injectables right now. So you inject them every 2 weeks. Some people see that as a positive, some people don't. The main use though right now is in the primary hyperlipidemias or severe secondary hyperlipidemias where statins are not tolerated. Because these statins aren't extremely clean, we have to make sure that we monitor patients for them. So at a baseline, check their creatinine and check LFT. So we're checking kidneys and liver function. Monitor this every year as you're checking their dyslipidemias too. So check in 6 weeks for initiating for adherence to therapy, making sure if you see some sort of response of their LDLs, and then you can check every 6 to 12 months afterward. In patients with extremely high ASCVD risk, so that's greater than 20, and they can't tolerate a statin therapy, right, because of the myopathies, then ezetimibe or PCSK9 inhibitors can be used then at that point. Beyond statins, and that's that whole chart with the fibrins and the bile resins and things like that, the recommendations are kind of all over the place and vary a lot between health provider and their own experience with them. So there's not much, there's not much consensus on what's going on. So recommendations tend to have weak evidence, but you tend to see a lot of these different things in practice, like increasing a moderate dose to a high dose. It seems like that would make sense, but a lot of studies show that no, you don't really get that increase that much. If patients aren't responding to the moderate dose, they're probably not going to respond that much to the higher dose, and you're just increasing their risk for liver damage and myopathy. Switching to fibrates, bile resins, or niacin, those tend to not have much success either. Again, if you're working with a patient and they're not having success with statins and they're not benefiting from them, that's probably the only option you have. But at that point, the options are not very good. Even adding ezetimibe is not great, not great studies. Now, for patients with really severe dyslipidemias, like the primary dyslipidemias, then that medication is really good. But for secondary dyslipidemias, there hasn't been much benefit. Again, when you're out in practice, sometimes you just get to that point where you have to try it. Changing statins. If you're going within moderate and then trying another moderate intensity statin, it doesn't seem to have that much benefit. You tend to go with the medication that's covered by the insurance. And then if patients are completely intolerant to it, like I said, they have increased LFTs that are sustained, or they have myopathies, then for secondary dyslipidemias, it's reasonable to try ezetimibe or the PCSK9 inhibitors like evolocumab or alirocumab. Of course, diet and exercise, right? Of course. So here's some links to really look at those, and I recommend them because whenever you talk to patients and you say, yes, you should do better with your diet and you should do better with your exercise, if you don't have specifics to tell them, then it's really hard to really follow any guidance, right? So here's some guidance here's some links that can give you concrete things to tell patients. The reason I really like the physical activity guide from the CDC is because it's by age group, right? It's not appropriate to tell a 70-year-old man to go out and jog, but for a 20-year-old that's having problems with his dyslipidemia and it's not as severe and you don't necessarily want to start a statin on them, well then they can probably do better with some more strenuous exercise. And now we're finally to the primary dyslipidemias. Again, these are the ones that are not necessarily acquired, they're genetic. So So here are the different types for the Frederick classification of primary or familial hyperlipidemias. You don't have to know all of these. I kind of just put these on here just so you can be familiar with the different types of pathology that are involved. You can see there are some that are involved with that LPL that we had talked about in the past, and a lot of them have to do with LDL receptor deficiencies or problems or increased VLDL production. The main ones that we're going to be covering are the ones that affect the LDL receptor deficiency and increased VLDL production. And the reason we're going to cover these are these are the most common types. The other ones you won't see that much at all. It's nice because there's a nice structure if we just cover these, and it kind of makes sense, but we'll just get to it. So don't memorize the chart. Just know that these two are the ones, or these two types are the ones that we're going to be discussing. And you look at the classic signs, they have different signs depending on the type, and it's because there's different pathology involved. So type 2A, or familial hypercholesterolemia, and we want to make that distinction here. It's an LDL receptor deficiency which causes an increase in the LDLs, increased total cholesterol, of course, if we're increasing the LDLs, but normal HDLs and normal triglycerides. Okay, so familial hypercholesterolemia, this is type 2A. If you're homozygous for this trait, then you tend to have a total cholesterol greater than 600. Those that are heterozygous tend to have it just 350, but you can see these are extremely high numbers. And it's not related to diet and exercise or anything like that. Those help modify those numbers, but even those patients that are doing well with diet and exercise are going to have these high numbers, so you have to treat appropriately. The classic signs for hypercholesterolemia are absolutely related to this increased serum cholesterol, and these are called xanthomas. Depending on where these xanthomas show up, you get different things. So xanthelasmas, the one picture here, are lipid deposits under the skin, usually around the eyes. Another type of xanthoma are tendon xanthomas. So we have Achilles tendon xanthomas, metacarpal xanthomas, phalanges, patellar xanthomas. Those are the really common ones that you'll see. So you'll see all these lipid deposits and deformations. Another big type of xanthoma is arcus senilis. So lipid deposits around the periphery of the cornea, and so that's going to be the picture on the top left, and the picture on the bottom right, but there's a difference between these two things. The one on the top left shows a severe familial hypercholesterolemia. The picture on the bottom right, though, it's also arcus senilis, but it's the type of arcus senilis that you traditionally see in geriatric patients. So there's just a collection of lipid for patients that don't have familial hypercholesterolemia, but over decades and decades of dyslipidemias, so secondary dyslipidemias, they get these deposits around the periphery. And you can say it's less severe. Okay, and you can also tell that's an older patient in the bottom right, whereas in the top left, much, much more severe lipid deposits there because of the level of cholesterol that we're talking about. The management for this, of course, is refer to cardiology. This isn't going to be something you're managing on your own as a family practitioner. One, they're pretty rare, but there's a lot of things that go on here that aren't just related to controlling their lipid levels, right? These people are going to have a huge ASCVD risk, so they have to be seen by a cardiologist. The management is going to be treating to an LDL less than 150, which is modified from a person without this disease. Treatment, of course, is high-dose statins. Generally, they're going to be on ezetimibe too, and then you have to have a strong consideration for those PCSK9 inhibitors. Another thing that's also available for these patients is lipid apheresis, which is very similar to dialysis, where their blood is run through and then all the LDLs are filtered out. Patients have to go through this on a regular basis, and there's not that many of them in the country. So it just kind of shows how rare these diseases are. Type 4 familial hypertriglyceridemia. You can see just from the name of this that now we're dealing with a different aspect of dyslipidemias. So this is an increased production and decreased elimination of VLDLs, right? Remember, VLDLs were our measure of, or it's what we use to measure and represent triglycerides in our cholesterol panel. So high VLDLs will cause high triglycerides. And the signs and symptoms of these are going to be different than with just your traditional high cholesterol levels. So instead of having an increased LDL level, you're going to have increased triglycerides, 200 to 500 milligrams per deciliter. You're going to have patients that have insulin resistance, obesity, hyperglycemia, hypertension, hyperuricemia, and they're going to be at higher risk for pancreatitis that's not related to alcohol abuse. Okay. This disease tends to be also related to early onset chronic kidney disease too. So these patients have a lot of problems with their kidneys like I said, it's management, of course, refer them to cardiology, and these patients are going to be mainly treated with fibrates. Okay, remember, statins are for LDLs. Fibrates tend to help triglyceride levels more. So there's no real use for HMG-CoA reductase inhibitors when you're not really that concerned about cholesterol levels. It's their triglycerol levels that are high. So fibrates tend to be the main treatment for these patients. And again, prodigious exercise and diet, of course. Type 2B is actually familial combined hyperlipidemia. It's combined because it's a lot of different things that are going on, but the main thing is that you happen to have increased ApoB increases and LDL receptor deficiencies. And apolipoprotein B is the main component of VLDLs and LDLs. Okay, so not only do we have an increase in the triglyceride levels, but we also have a high level of LDLs. Okay, so combined hyperlipidemia. So as you would expect, the signs and symptoms of a combined hyperlipidemia are related to signs and symptoms of high triglycerides and high LDLs. So patients can have all those manifestations of xanthomas and pancreatitis. Okay, obviously because of all the things that are going on here, these patients are going to have really early onset coronary artery disease, peripheral artery disease, right, leading to angina, claudication, TIAs, strokes, and they tend to have high LDLs and triglycerides as teenagers. That's when you see these. So it's rare, but you'll definitely see it out there. Management, of course, refer to cardiology. High-dose statins and fibrates, add ezetimibe if necessary, add evolocumab and alirocumab if necessary, and then lipid apheresis, of course. The interesting thing about it is that really, even though the treatment you do see with high-dose statins and fibrates, kind of the recommendation now is switching to just high-dose statins. It makes sense, right, that if you have triglycerides and LDLs, that both statins and fibrates would be useful, but it's not actually what the evidence shows. So there's not much increase in benefit of the triglyceride lowering, even though you add a fibrate. Okay, the only problem is, again, you have myopathy and rhabdomyolysis increased risk for if you do that combination of medications. So that's dyslipidemia, right? We talked about a whole host of things here, and so I'm going to put the objectives up here again. It's a lot of different things, you know, basically statins are the answer, but if anyone has a question, let me know, and just keep safe out there, guys. Thank you.